go over some housekeeping issues. We continue extending CME credits for our Tech Talks and our ID series presentation. We will distribute the information via email to those that registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Lacey Long. Her email address will be posted or is posted in the chat box. I just wanted also to mention our next ID series, which will be on May 11th, and that would be Dr. Melissa Bondi from Stanford, who will talk about molecular and genetic epidemiology of glioma. So you really do not want to miss that one also. So I'm really happy to introduce Dr. Eberth. Dr. Eberth has been professor and chair of the Department of Health Management and Policy in the Dornsife School of Public Health at Drexel University since 2022, as well as member of the Cancer Risk and Control Program at the Sidney Kimmel Cancer Center at Jefferson. Prior to 2022, she was Associate Professor of Epidemiology in the Arnold School of Public Health, University of South Carolina in Columbia, South Carolina, and also Director of the Rural and Minority Health Research Center. She obtained a PhD in epidemiology from University of Texas Health Science Center School of Public Health, and she was a postdoctoral fellow at University of Texas MD Anderson Cancer Center in the Health Services Research Section. She has been extensively funded by NIH, HRSA, the Federal Office of Rural Health Policy, and the American Cancer Society over the years. She has a very impressive peer-reviewed publication list as well as impressive media coverage. She's a teacher and mentor for numerous graduate students, postdoctorate fellows, and faculty. And she also has received many awards and honors. For example, she was invited as a rural health stakeholder for the White House Office of Public Engagement. And she's been invited all over the US to give talks and lectures. So we're extremely lucky and honored to have Dr. Eberth today. Thank you.
Thank you. That was such a kind introduction, and I'm also extremely honored to be invited and be here to present to you. Can everybody hear me okay? Awesome. Okay. Well, thank you for the invitation. This is a delight for me. As you know, I'm new to the area, so getting to know the sort of tri-state area and meet new networks and connections is really important to me, and these opportunities are just a stepping stone in that direction. And I already know a couple people on the call as well, so thank you for the invitation and kind welcome. So today I'm going to be talking about lung cancer screening, and before I jump into a lot of logistics about how lung cancer screening is offered and how it came to be the screening of choice that we now promote, I think it's important to generalize some of its epidemiology to know where we came from. And for those of you who don't know much about lung cancer, it is an extremely deadly cancer and contributes to more deaths than breast, prostate, and colorectal cancer combined. It accounts for about 22% of all cancer deaths. And unfortunately, because of the stage distribution of cancer, as you can see in the figure on the right, most people who are diagnosed at a regional or distant stage. And because of that, survival is much lower than for many other cancers that we know and treat. So 5-year survival is only about 23%. But if you look at the survival rate amongst those that are diagnosed at stage 1, the earliest stage, the 5-year survival rate is more than 60%. And that's important and notable because lung cancer screening, which we'll be talking about very shortly, has an opportunity to help improve the stage distribution of lung cancer, really shifting more people who are traditionally diagnosed at later stages to earlier stages and therefore improving their prognosis. In thinking about the early detection of lung cancer, I think it's important to know the historical angles of how we came to be recommending low-dose CT today. In the 90s, there were several trials that began. The PLCO trial looked at not just lung cancer, but also prostate, colorectal, and ovarian. And this RCT is quite large. It compared differences in lung cancer mortality, comparing an annual chest x-ray to no screening at all. And in that trial, they found there was no reduction in lung cancer mortality by using a chest x-ray. This is really important evidence for us because up to this point, chest x-ray was something that physicians would readily order to diagnose lung cancer, or I shouldn't say to diagnose, but to screen for lung cancer, without as much evidence that it actually worked. And the Early Lung Cancer Action Program, also known as LCAP in the 90s, did a similar trial. Their approach was a little different, but their focus was on looking at differences in proportion of stage 1 diagnoses instead of lung cancer mortality. In this study, they compared having an annual chest x-ray to a low-dose CT. And they found that there was a difference between the two groups, and the annual low-dose CT screening did actually help diagnose more people at stage 1 than chest x-ray. But the trial wasn't designed to test mortality. Well, the NLST began shortly thereafter in the early 2000s, and the sort of seminal paper from that trial, the National Lung Screening Trial, was released in August of 2011 in the New England Journal of Medicine. And this really set off a paradigm shift and allowed us for the first time to have evidence that a modality would improve lung cancer mortality or reduce lung cancer mortality, which had never been shown in a previous large study. So a little more information about the NLST for those of you who have not learned about it. The National Cancer Institute sponsored this trial. It was a very large and most expensive trial they've ever run. Over 50,000 individuals that are at high risk were randomized into two groups: low-dose annual CT versus annual chest x-ray. So first off, I want to point out one of the things that sometimes you'll hear critiqued with this study is that, it didn't have a comparison of nothing at all, which when you think of trials, sort of a no screening or no treatment is often one of the control groups. And in this case, we were comparing chest x-ray to low-dose CT. The primary results of this, the two biggest ones, are that there was a relative reduction in lung cancer mortality of 15 to 20% in the cohort, and about a 7% reduction in all-cause mortality, which is also quite positive. Both of those were significant. And when you look at some of the problems with the test itself, one of the things that's often brought up is the high number of false alarms or false positives that can be found to be associated with either of these tests. So with both chest x-ray and low-dose CT, more than 90% of quote-unquote what we call positive screens are false in the NLST. Now, that may be partially due to the threshold that was used to define positivity. That threshold itself has changed over time as we've learned more about how lung cancer should be best described. And there's now a new classification system called the Lung-RADS system that it does a much better job at distinguishing cancers. It has a slightly lower sensitivity rate, a higher specificity rate, but overall has fewer false alarms associated with it, and it does quite well in practice. One of the things I want to point out as well about the NLST is the importance of adherence. Sometimes people, when they think of lung cancer screening, think of it as a test they would do one time or a few times, but really the benefit of lung cancer screening is that it's done annually over a long period of time. If you look at this figure on the right, at the top you'll see the cumulative number of lung cancers at A, and then on B you'll see the cumulative number of lung cancer deaths. And what you'll probably notice straight away looking at this is that, people who get low-dose CT, that type of test automatically finds more cases. That's what you see in panel A. But in panel B, the benefit of screening, you don't really see a difference or a gap between low-dose CT and chest radiography until about year 2 to 3. So this suggests that, you really need to be thinking about screening in terms of the long-term piece. If you screen in one time, it doesn't actually show any difference. It's really multiple years after randomization and continued annual screens where you really see the benefit. And subsequent research has shown that if you include more diverse participants in the original NLST study, that the reduction in mortality would be even greater than the 20% number that's typically reported. They say it would be up to 45% in a population that had, if you had limited just the NLST cohort to only Black participants who were current cigarette users, you would have up to a 45% reduction in lung cancer mortality. So definitely some differences across people who participate in the study in terms of how they could benefit from the actual test. When you look at the study and you try to think about what are the risks and benefits of the screen of low-dose CT, it is something that we need to weigh because there are both risk and benefits associated with it. The most obvious benefit is this 20% reduction in lung cancer mortality, and the reduction is even higher in minoritized populations and those that are at higher risk. The sensitivity is quite good. There are studies that have shown that people who have a positive test, regardless of whether it's a false positive or not, are more likely to stop smoking as a result of having that positive test. So that's a sort of surprising but positive finding. And then also there's a high rate of incidental findings because you can imagine when you're doing a CT of the chest, there are lots of other things you might find in terms of cancers, cardiovascular, other conditions, and they can find and treat those if they are found during a low-dose CT, which is a really positive thing. And then from a risk perspective, we have to think of, well, what's going to happen with false positives? One, it can cause psychosocial distress. People being told that they may have cancer can be distressing. And studies show that that is true, but that the level of distress goes away pretty quickly, especially if people are reassured and given the appropriate messaging about what a false positive really means and the importance of annual adherence and follow-up so that nodules that are maybe, concerning can be watched over time. It's quite, versus, telling people, oh, you definitely have cancer. We need to message it right. There's also concerns about overdiagnosis. In the NLST, they estimated about 1 in 5 people would be overdiagnosed using the test, so that is concerning. And overdiagnosis essentially indicates that people would have been found to have lung cancer that it never would have caused their death or major serious complications. And then in addition to that, there's been estimates that have indicated that there is a possibility of radiation-induced cancers from having annual low-dose CT, and that's estimated to be about 2 to 6 per 10,000 persons. So when you look at the timeline of screening, I told you there's a paradigm shifting, a seminal article that shows the results of NLST that came out in 2011. And unfortunately, it took about 2 years from that point to when the USPSTF released their screening guidelines recommending that the population begin screening people who meet the criteria of being a high-risk person. Again, about 2 years later, we received a coverage memo. So this is the Center for Medicare and Medicaid stating that they would cover screening as a preventative service. Now, for various reasons, they decided to limit the population who should be receiving reimbursement for the test to persons aged 55 to 77, despite the fact that the 2013 USPSTF guidelines indicated that people 55 to 80 should be screened. Between 2015 and 2021, when new guidelines came out by the USPSTF, a lot of important things happened. One of the biggest things that happened in that interval is that a trial called the Nelson trial, results were released in the New England Journal, really confirming our findings that low-dose CT does indeed reduce lung cancer mortality. In fact, they found probably better results than NLST. They had a very small proportion of their cohort that was women, so there were some limitations. But nonetheless, it definitely confirmed what we know about reduction in mortality, and it expanded our knowledge of other populations that could benefit that are younger in years or have lower smoking intensities as well. The amount of screening programs in the U.S. really burgeoned during this period of 5 years. There was a tenfold increase in screening programs. It started out with just about 200 in 2013, and now we have over 3,000. So there's really been a big increase. And we also have seen positive increasing signs of screening uptake, but I still want to emphasize how low the rates are. And later in today's presentation, I'll share with you some of those numbers for the nation, for your state, and so you can get a sense for where you fall and how long we still have to go to reach the kinds of numbers that you see in other types of cancer screening to date. And then this last year in 2022, we had an updated coverage memo. Now the Centers for Medicare and Medicaid is covering screening for the population that is lower than 55 years old and also has lower smoking intensities. So the USPSTF, that is a mouthful. Those guidelines changed, as I mentioned, between 2013 and 2021. And the biggest difference between those two criteria are the lowering of the age, the interval at which you would start screening. You can see that in 2021, it starts at age 50, and then the PAC years of smoking history went from 30 plus to 20 plus PAC years. And just for those of you who may not know, a PAC year is essentially saying that you smoked a pack a day of cigarettes for 1 year. That would be one PAC year. So people who smoke 2 packs a day, they would need to smoke fewer years to meet these PAC year thresholds than a person who smoked 1 pack a day. That's what that references. And these new criteria, if you apply them at a population level, double the number of screening candidates in the U.S. from about 6 million to 14 million people. The guidelines also are quite nuanced, so I want to share with you some of those nuances. The first is that the task force recognizes that these benefits and harms do have a balance, and that patients and providers should be discussing that balance in each individual person's unique circumstance, considering their life expectancy, considering the likelihood or ability that they could receive surgery if they found a positive finding, for example. So it should involve what we call a shared decision-making visit. And unlike other types of screening, Medicare will actually pay for a shared decision-making visit that precedes a person's baseline exam. This is unique to lung cancer screening, and it's, to me, a great thing that can help build patient-provider communication. To some, it is considered a barrier to screening because it's an extra step someone has to go through. So I see both sides of the argument. There have been some things that have been done over the years to try to make shared decision-making more palatable and easier for both the patient and the provider. There have been many wonderful decision aids developed, for example, and we'll talk about some of those shortly. If a person decides to be screened, they need to be referred to a facility that is, a high-quality facility, a place that offers a program of standardizing the lung nodules and using something like lung RADs to characterize and report on the findings. So research indicates, unfortunately, that shared decision-making really isn't happening all that well in the real world. Brenner et al., this is a colleague of mine from UNC Chapel Hill, did a great study that it actually sort of audio, it recorded visits between patients and providers, and they found through those recordings that the discussion about lung cancer screening took less than 1 minute on average. Another study found that more than 90% of people who had private insurance had no billing claim for shared decision-making prior to having a billing claim for the lung cancer screening itself. So even though it's supposedly required for people to have shared decision-making before screening, it's not always happening, or if it is happening, it's not being billed or recorded in the way that we would have hoped. Another thing, some colleagues and I from Wake Forest University did a study in their cancer center, and we interviewed 75 patients who had seen a primary care doctor within 5 days So they had an order for a lung cancer screening test, but had yet to receive a lung cancer screening. And when we called and spoke to these patients, we found that most of them had not discussed any of the harms of lung cancer screening during their visit with the primary care physician. Benefits were talked about by almost everyone, but very little people knew about or had their primary care doctor talk about the harms. When you talk to them about their knowledge of different components of screening, their knowledge scores were also very low. They actually were pretty confident about their ultimate decision whether or not to get screened, but when we did a sub-analysis, we did find that Black individuals in our sample had more uncertainty about their decision than the white patients that we had interviewed. And that actually aligns with other literature from other types of cancer where they've looked at decision certainty. So there are different types of decision aids and interventions to promote the use of shared decision making. Some good ones that I'll note here, shouldiscreen.com, for example, is a really nice tool that was developed out of University of Michigan. There is a wonderful video produced by MD Anderson. There are some great risk calculators that are both measuring not just whether you meet USPSTF criteria, but whether you have some other risk factors. There are pack year calculators online. There are sort of Q&A style web-based decision aids and obviously paper brochures and flyer type of decision aids as well. And all of these are really wonderful. Unfortunately, they're really underutilized in practice based upon surveys of physicians who have been asked about their use of these tools in real clinical settings. The USPSTF guidelines are really important from a payment perspective. The Affordable Care Act indicates that services that have an A or B rating must be fully covered by private insurance plans that we call non-grandfathered plans. Grandfathered plans still do exist, so there are many people who would not be eligible for it, but these are waning over time. Medicaid makes a decision state by state about coverage because Medicaid is sort of a state-based program. So unlike Medicare where they make a decision and it applies nationally, you have this sort of state-by-state approach with Medicaid. The American Lung Association has a really wonderful report they put out every year called The State of Lung Cancer. And in that report, they talk about each state's rules and regulations about whether prior authorization is required, whether they cover screening, and other sort of policy elements of that decision. So in Delaware, based upon that lung cancer, state of lung cancer report by the ALA, no prior authorization is currently required, and patients will pay no copay for their lung cancer screening. This is essentially the best case scenario in your state, so that's great. One of the things I will point out, though, is just last month, about 1 month ago today, U.S. District Judge Reed O'Connor struck down a really important provision of the ACA that requires a cost-free, no cost to the patient coverage for cancer screening in private plans. So this has been immediately appealed. It was appealed within 1 week of that judgment by the Biden administration and will continue to go through the courts. But this would be a major letdown for us as researchers and practitioners and public health advocates if this were to go through. Essentially, every cancer screening that has been recommended by the USPSTF in the past 15 years would automatically be private insurers could choose not to cover it as a preventative service. And that cost will be passed on to the patients. So there's definitely an advocacy piece here that we should be well aware of and making sure we are doing our due diligence and our best to try to make sure that, we do all that we can to preserve these kinds of important services for patients. From a payment perspective, there are also, I don't know if there are any physicians on the call or any folks involved in billing, but there are CPT codes that are used to pay for lung cancer screening itself as well as this counseling visit. The counseling visit can be done in person or via telehealth. That's a new thing. With the COVID-19 pandemic, it was added as a telehealth service. And this can be done for about $75. It can be billed. The exam itself is billed for about $105. And of course, like all billing, you have to be very careful which ICD-10 diagnosis codes you put in along with the claims to make sure you get full payment for these services. So as I mentioned, these new criteria double the number of screening candidates in the U.S., but in addition to just looking at that total number increase, it's important that we look at the differences in who's eligible, because this newly eligible population is more likely to be female. They are less likely to have some comorbidities and COPD. They're more likely to be highly educated, and they're less likely to be white. So this is a really interesting shift in who's likely to be able to be screened. One of the reasons for changing the criteria in the first place is that studies were finding that people with cancer who were minorities and who were female were less likely to be eligible under the 2013 guidelines, even though these people had lung cancer. And so those criteria really didn't have good they weren't as discriminate in finding people who were truly at risk for lung cancer. Non-Hispanic, or I should say, individuals who are people of color and also persons gendered as female are more likely to have lower smoking histories and get lung cancer at earlier ages. And so that's kind of part of the problem with those original screening guidelines, is they were not getting into the pool of eligibles for those reasons. For those of you who keep up with the National Comprehensive Cancer Network, NCCN criteria, these criteria are more, they even include more people than USPSTF because they have an added category for other risk factors associated, for example, with occupational exposures and family history. And the NCCN criteria has been found to capture more persons that are Hispanic than USPSTF. Prediction models have also outperformed USPSTF. They're found to be better at eliminating racial disparities, in particular in mortality. So as I mentioned, screening uptake has been pretty suboptimal. In 2015, less than 4% of eligible persons in the U.S. reported being screened, and you saw really equally low rates in both urban and rural communities. But when you look at the distribution of screening uptake by percent eligible, there's really a disconnect, because the Northeast, for example, in 2015, about 10% of people who were eligible were screened in the past year. But yet the Northeast was actually the population that had the lowest proportion of people that were even eligible. So it's great that you have high uptake, but the population who needs it most doesn't actually have the strong levels of uptake that you experienced here in the Northeast. So really there's this disconnect between the two types of the proportion eligible and the proportion screened. We also had looked at some data from the 27 BRFSS. In this, because lung cancer screening is an optional module in BRFSS, only 10 states agreed to participate, and in those 10 states, over the total, 14% had lung cancer screening, but you can see there's quite a lot of variation state to state. In Florida, for example, it was 18%, but in Nevada, it was only 6.5%. So these substantial differences are important to note. Of course, there are some pretty wide confidence intervals that do overlap, but not in every case. Additional analyses we did from that same data set suggested that things like COPD, prior cancer history, and having health insurance were predictive of being more likely to be screened. The following year, 2018 and 2019 BRFSS data, we collated together, and among the 20 states that had lung cancer screening module included in their survey those years, 17.5% of people had lung cancer screening in the past 12 months. In the early studies, disparities weren't really shown very much because so few people were getting screened. It was really hard to discern any kind of differences between population groups. But I've noticed as we've looked at this data over time that disparities are beginning to emerge. So in the table on the right, for example, you can see that by age, there's sort of a decreasing trend or less likelihood of being screened as you age. Persons who have report having an inability to pay for medical care over the past 12 months are much less likely to be screened. Persons who are uninsured and persons with the presence of comorbidities are also less likely. But, you know, our studies did show that there are some positive things to note too. So non-white persons are equally likely to be screened in this data. You can see the confidence interval includes 1. Rural populations equally likely to be screened. And on a really positive note, we found that veterans were more likely to be screened, which really points to the wonderful programs that the VA has developed and implemented to try to screen their patient population, and such as VA PALS program, the LPOP program, and others. So in Delaware, about 9% of those who are at high risk are reported to have been screened. This data does not come from BRFIS. It comes from the American Lung Association. They have their own estimation process. I have some uncertainty about the quality of this data because it is based not on sort of your traditional population-based data set like BRFIS. On the positive note, in 2022, every state in America will have included lung cancer screening in their BRFIS survey. So we'll know for certain what the values are in each state, and hopefully Delaware will remain, you know, above average and in this higher tier that the ALA estimates that you're doing quite well in that space. Unfortunately, we're still very early and very few people are getting screened. So even the majority of people don't even know about screening. There's a lot of reasons for that, and I bring here this framework from Everett Rogers. Some of you may know in the 60s, 70s wrote a book called Diffusion of Innovations, and I really think this theory is well applied in the lung cancer space because there have been people who adopted lung cancer screening quite early, and some colleagues and I from Jefferson are actually doing a study right now to look at who these early adopters were. Our research does suggest, for example, that it's people who smoked less, for example, sort of healthier people that were getting adopting screening earlier. So to reach more people in this Bell diagram, we're going to have to do a lot of different things. But the most important thing is really be better communicators, helping to reduce fear and stigma associated with lung cancer and talking about smoking at all. I mean, there's just been incredible stigma, even on the behalf of the public health community. When you see the commercials on TV, for example, they may be great at sort of shaming people into not smoking, but it also may shame people away from talking about the fact that they are a smoker with their healthcare provider. So we need to reduce that fear and stigma and try to reduce the barriers for people to make it through the healthcare system. We need to try to simplify processes and provide tangible results to people so that they see the true value of screening, both initially and from an adherence perspective. The literature is ripe with studies looking at different reported barriers to screening at multiple levels. So I'll just talk about 2 here, but there are also additional levels at the clinic, healthcare system, and societal level. But at just the patient and provider level, you can see there's a variety of things the research indicates. There's a lack of awareness of screening itself, a lot of psychosocial barriers around stigma, fear of perceived diagnosis, sort of fatalism, cost and billing concerns about how long it's going to take to get from where one lives to a screening site. This was particularly a barrier in the beginning when there were so few screening programs. And even though we have 3,000 screening programs today, in some states, particularly in the Midwest and West, there may only be a couple screening sites in the whole state. So this is still an issue, particularly for rural patients. From a provider perspective, a lot of the barriers are sort of system issues, like having to deal with doing prior authorizations, not knowing how to manage these incidental abnormal findings, just the time constraints and the many things that patients come in needing to deal with. So screening doesn't always fit within the 15-minute appointment they have with the patient. There's really difficult use of EMRs capturing lung cancer screening eligibility. There's few systems that have alerts to alert people that someone is eligible, frankly, because we don't have very good eligibility data in the EMR. So what's the point of an alert if we don't have good eligibility data? So that is a major hurdle. And then there are still providers who are cautious about screening itself. They feel it's not as effective as the literature indicates. There's concerns about the amount of radiation dose and other potential harms that patients may experience. And that was really quite prevalent at the earlier part of the decade, but has gone away some. And one of the evidences of that is that the AAFP, the American Academy of Family Physicians, they did not support lung cancer screening when it first came out. Their recommendation was sort of an insufficient recommendation. There's insufficient evidence to recommend for or against. But in 2021, after the new guidelines came out, they changed their tune, they changed their recommendation, and now they do support screening. So there's definitely been a shift as more evidence has come out. We've gotten better at discriminating positive and non-positive exams. And, we've seen that screening in the community can work, not just in the trial setting. This is a map pulled from a cancer study published in 2022. And it really shows what I was trying to say before about how many parts of the Midwest and West have very dispersed screening sites throughout the state. They may only have a couple. And because of that, some of the participants are some residents who would be eligible for lung cancer screening are going to have a very difficult time getting care. Over 60% of the population that's 50 to 80, so this is a potentially eligible population. People that live in rural counties that have no screening center within 20 miles. You can see there is a swath of screening centers in Florida and in the upper sort of northeast and around Michigan, Illinois, Indiana. So there are definitely clusters where we have a lot of services. They typically are in urban areas. So this maldistribution, it's not unique to lung cancer screening. It's really present across all different types of screening, but we'll need to think of ways to overcome it if we're intending to meet the needs of all of our population. This is a framework from the late 90s that I put up. It's Cabana et al. Published in JAMA. And I put it up because when you're thinking about what are these provider barriers to screening, many of them are related to the inconsistency of the guidelines, the fact that physicians have so much to do. They have a lot of other competing priorities in their practice. They have routines that they follow. When new guidelines come in, it's difficult to integrate them into their practice. And I just think this framework does a really good job describing the many different ways that physicians may not adhere to practice guidelines, and especially adhere to them right away. I think it becomes easier over time as they get incorporated into their routine practice, become incorporated into EMRs. But there's a lot of reasons why we don't expect them to be able to overnight make the changes, and we've seen that happen in reality. So some key takeaways I'm going to present, and then we'll just briefly talk about some implications and interventions. So my research, as well as other research, does indicate these findings. So we know that annual low-dose CT screening amongst high-risk persons reduces mortality. Unfortunately, we continue to notice a distribution issue, both geographically with urban versus rural populations, but also regional differences between the Midwest, West, Midwest, and South. The South has the highest proportion of eligible persons, but still had one of the lower screening uptake rates. Screening uptake is still much lower than for breast, colorectal, and other types of screening that have been around for much longer. We do see significant geographic variation across the U.S. states, and unfortunately, the data indicate that these disparities are beginning to emerge with age, insurance, and economic-related variables. The barriers and facilitators to screening are present at multiple levels, and if we put the patient at the middle, at the center, trying to make sure that they are truly, that this whole process of making lung cancer screening available, implementing it, evaluating it, is truly all about the patient at the center, then we need to be thinking of our interventions not just at the patient level. I think a lot of times interventions are put forth to change behavior of individuals, and fewer interventions are focused on making the system and the providers and the policies better to support the patients. So instead of presenting you with patient-level interventions, I present you with provider, system, and policy ones, because I think that's where we're going to get the most bang for our buck. And in fact, literature reviews cite that the most effective interventions are typically not at the patient level. So for lung cancer screening in the provider setting, we definitely have work to do in terms of increasing awareness about screening, knowledge of what the guidelines are, and helping to increase SDM and referrals. As I mentioned, shared decision-making is really not happening universally amongst providers before they refer to screening. And in some cases, that's appropriate because shared decision-making is happening centrally in a program. But we don't really know that for sure, especially in these large data sets we're looking at, where it's hard to disentangle like where shared decision making is happening in each of the different healthcare systems. In the healthcare system, there's a lot of ways we can improve as well, particularly around scheduling. This has been a challenge. Lung cancer screening, because it happens in such a fragmented way, with the shared decision-making often happening aside from the lung cancer screening. And once you have a report, do you report back to the primary care physician or the patient? Like, it's just a challenge. So I think better tracking and scheduling is important. Using patient and provider reminders is important. And from a policy perspective, there's a lot of different things we can do. I've listed just some of them here. One of the ones that I'll share is if any of you are associated with or knowledgeable about the CDC's National Breast and Cervical Cancer Early Detection Program, you know that screening is offered. Sorry, it scared me a little. It's okay. It just scared me.
I'm sorry.
Screening is available and provided for free to uninsured persons through that program. And that is, funds are given to the states to implement this program. Most states do not offer lung cancer screening to the uninsured. They do not include lung cancer screening as part of theirs. I was delighted to see that Delaware is not in that group. The Screening for Life program appears to offer free screening tests for breast, cervical, lung, colon, and prostate. So you are in a unique group that does provide these additional services to uninsured low-income residents, because that's not required through the national program, and funds are not provided for that purpose. So just a kudos to you for doing that and making sure that if you have patients who meet these eligibility criteria, definitely have them call and get screening through this mechanism so that they're not paying out of pocket for those services. Another thing that our research has shown is that there's an opportunity to leverage mammography to improve lung cancer screening. We did a mixed method study a couple of years ago of mammography program directors across the U.S. This survey was facilitated by the American College of Radiology. And in this survey, 72% of the directors that responded to the survey said that their clinic would be receptive to informing women about their lung cancer screening eligibility status. which was really positive that so many of the program directors, were thinking about something other than mammography, even though that wasn't their job. However, these directors really said, well, not having enough staff was a major barrier to doing the actual ascertainment of eligibility or making referrals. Sort of lacking time to do it in the visit itself was also a major barrier. So it's not an easy thing, but it has been shown to be effective. Vanderbilt, for example, has a really good program to integrate their mammography centers with their lung cancer screening center and to increase referrals through that program. If you would like more information about that program or want to learn, connect with the director, I would be happy to connect you. Because I do think this is, mammography is a very well accepted screening modality. It's one of the highest utilization rates amongst cancer screening types that we have. So if we can leverage that, the strong acceptability that women have to getting a mammogram, to using that setting to identify additional people for lung cancer screening, that would be a major win. We also can think about the emergency room as an opportunity to expand screening. A study published last year found that people in their ED cohort that they studied, there was 183 out of 500 people were eligible for screening in that cohort. And that they found that less than 1% of those people knew that lung cancer screening was the preferred method, or that low-dose CT was the preferred method for how to get screened. And less than 10% of people even knew lung cancer screening was a thing, right? So there's a long way to go, but you can see that there are definitely people who come into the ER every day who would be eligible for screening. And we need to think about how we can leverage these opportunities, which are currently missed opportunities, to educate and refer people for screening if appropriate. And lastly, I also think it's important for us to think about how we design our screening programs. A lot of large healthcare systems discourage a decentralized screening model. They prefer a very centralized approach where everybody comes in to one radiology unit or pulmonary unit, and they get their shared decision making right there, and they get their exam on the same day, and they have a great tracking database, and that's wonderful. But studies, even though there are high adherence rates and SDM is always done in these centralized programs, from a patient's perspective, it doesn't always translate to having better access. Because to get into those programs, there can be additional hurdles versus having just the PCP order it right on the spot during their visit with their doctor every year. So I would say we really need to do more research on whether these types of centralized, hybrid, or decentralized models are good from the patient's perspective, not just good from a sort of program effectiveness and logistics perspective. Just wanted to acknowledge I had a lot of people over the years that have helped me with these types of studies I presented on today that are listed here, and grants along the way, so I have to always give them a shout out as well. Okay, and I'm happy to take questions and just chat while I have a little bit extra time with you all today.
Well, thank you so much. This was a wonderful talk. Very, very informative. We have some comments in the chat from Nora Katurakis, who is the Cancer Outreach Program Manager at Christiana Care, so she has a lot of knowledge on the cancer screening.
Claudia, can I just first apologize?
Sure,
I sneezed. I am so sorry. I apologize. And I didn't mean to scare you. Okay. But I did. Thank you for mentioning Delaware in your data. And I do know that Delaware, and I put in here, I thought we were adding the Burfus question on the Delaware Cancer Consortium. And I thought the next time that those special modules are offered, I think we did review that question to be added. I just don't know what year we're doing that, or we already did it. Because we were talking about metrics to measure our success. So, That was one thing. And then the second
Yeah.
thing, I did put the link for the healthydelaware.org, which has a great new website that's been really updated over the past year, that has the Screening for Life criteria. It has the nurse navigator numbers. We didn't have this years ago either, and it's really become a wonderful resource for you or for me to reference if I need help to get in contact with anybody that might help with the cancer screenings, not just lung. So
Yeah.
I just want to
And
put all
I'm
that
just
in
curious, do you know the lung cancer screening portion of Screen for Life? How is that part funded? Because I'm pretty sure that the CDC's funds can't be used for
Now,
anything except for breast
so
and cervical.
so this goes to your comment about policy. Being a member of the consortium for nearly 21 years, we have always said that it doesn't matter about breast and cervical. We get the funds there, but when we look at our data, we needed to focus on adding colorectal, which we did at the time, and impacted the disparity there. When lung came to be, it was a little bit harder, but they added legislative funds to that. So there is
great.
in our budget for lung screening. And there will continue, I believe, to be money in the legislation approves that money, and prostate's in there, and then there's some other things to help with to assure care. So we are one of the, and the Delaware Cancer Treatment Program is the other piece that pays for up to 2 years of cancer services for those that are uninsured, and that covers at 650% poverty. So interesting that we're one of the states that does that. I think maybe one of the only. So
there are very few.
But thank you for your presentation.
Any question for Dr. Eberth?
I guess we should say that Maryland too, with our Cecil County, I see Lisa Fields is on, and Maryland does lung screening. Were they a part of that Burfus data? I forgot who those people were. I think Maryland was in that. Mm-hmm. Yeah, I just thought about that.
And I'm almost positive. I think it's 2022 that every state will then have lung cancer screening. It's not going to be an optional module anymore. It's going to go for everyone. So I think we'll really be able, once that data becomes available and hereafter, we'll be able to look at this in a way we've never looked at it before, because we'll really have our first national picture of screening uptake. So far, it's just been, these 20 states or these 10 states. So it'll be wonderful once that is released.
I had a question about Medicaid. So there are some states that do not allow Medicaid to pay for the screening.
Correct.
Are there studies related to mortality or to the number of cancers that are diagnosed in these states in relation to lung cancer?
Yeah, I don't know of any studies that have purposely looked at the relationship between when a state, if they did at all, began covering lung cancer screening through their Medicaid program and associated reductions in mortality. I'm not aware of any study that does that. That's a great idea. The landscape has evolved very quickly, because just a few years ago when I looked at that state of lung cancer report, it was about half the country didn't have their Medicaid programs that would cover it. And now it's only like three states that don't. So it's really quickly improving, where states are beginning to cover this through their Medicaid programs. Many more states require prior authorization, but only 3 don't cover it at all.
And that, I think, is an important point, Jan, because we talked about, even in our state, that it becomes a barrier when you have to pre-auth, and it becomes a burden on the model to the imaging to have to pre-auth people who we know we would like to expedite more quickly if they're ready to go. And just how impatient we all get when we want to do something and then we have to get an approval for it.
Yeah. I've heard so many horror stories lately about the pre-auth process and how so there are many claims or many of these there's a lot of denials that happen for like no good reason at all, and that is borne out when I speak to people who tell me how many times they've been declined for patients that are eligible. So I'm a skeptic of that whole pre-auth system and thinking that it's doing more harm than good, but I know why it was set up. But unfortunately, in the interest of making profits, I think that the actual process of reviewing claims in a thoughtful or reviewing authorizations in a intelligent way is not happening as it should.
And it's denied. I'm sorry, go ahead.
Go ahead. No, go ahead, Claudia.
And you are saying it's denied by the private insurance? Oh.
I've heard stories on both public and private.
Jan, do you know of any groups that have reported that mobile lung screening units have made a difference in eliminating the disparity? I know everybody has a strong passion for mobile units, I'll put it that way, but truly are they, when you look at, you screen and then you have to rescreen populations year after year for the round 2 and 3. Can you comment on that at all?
Yeah, I'm glad you brought up adherence, because if you think back to that one figure I showed where the adherence really popped, it's important for reduction of mortality. You don't really see it until year 3. So yes, it's super important. I do know multiple states, health systems that have the lung cancer screening vans right now. And some of them, I would say all of them are collecting some level of data, but have not published on reduced. I mean, it's frankly hard to publish to say that you've reduced disparities because of the nature of how the van works. It goes all these different places, and sometimes it goes to this county only once. This one it goes to 10 times. So it is difficult. Maybe that's a project that Scott might be interested in working on. It's kind of a spatial problem, right? Because you have to know where it goes, know how often it goes there, know how many people it's screened on each visit. It becomes difficult to say, well, what is the thing we're going to measure as a pre-post to say that the disparities were actually reduced in that community? So I know that some people have written about the process of their screening van, but showing reductions and positive outcomes I have not seen. Others may have, and if so, please feel free to mention.
So there is a comment in the chat from Jamie Conley-Mahan commenting about the Cecil County Health Department offers no-cost lung cancer screening for eligible low-income Maryland residents, funded by the Maryland Cigarette Restitution Fund.
That's a good use of that fund.
And Scott has added a comment. Do you want to comment on your comment, Scott? I'm very interested in doing work on special access.
I was just going to say it's in the queue. We're looking at access to lung cancer screening by community using spatial methods. So I'm happy to talk to you more about, Jan.
That's good.
All right. I think it's 1, and I guess we need to adjourn. So thank you so much, Dr. Eberth, again. This was a wonderful presentation.
Thank you. It was a